So I wanted to go over some of the factors that we have to take into consideration when dealing with children's fractures. And of course, that can entail a lot of different things. If you think of, in my practice, the fractures that I see the most, of course, are in the hand and wrist, which I see elbow and shoulder fractures as well. Um, but one of the things I find is that in many cases, and I would say in most cases, there's a lot of treatment and information and education that has to be done for the parents as well in terms of what to expect and understanding. And also, I think that there's some level of confusion that occurs when treating these fractures, specifically when reduction or setting of the bone is needed, depending on the location. So one of the first areas to think of is when you first have a fracture. Let's say you didn't go to our urgent care, orthopedic urgent access, and you went to the emergency room, and emergency room doctor tells you that there may be a fracture there, or there may not, or there's definitely a fracture, but it's not displaced. And then let's say you come into the office to see me, and then I tell you that I don't see a fracture, an obvious fracture on the x-ray, but we're going to treat it as a fracture and put a cast on. So that's a pretty confusing situation because you've gotten kind of quasi answer from the emergency room, and then a similarly nebulous answer from me as a physician. And the question is, why is that? And primarily because a lot of times when you're not dealing with fractures or broken bones that are widely displaced, meaning that they're really crooked or obvious, or just, of course it's broken. I mean, anyone can see it. If it's not one of those types of injuries, you have to realize radiographically on x-ray, when you look at the x-ray of a child, a lot of the areas where the growth plates are just not calcified. So you literally can't see it. So in those cases, a lot of the diagnosis of fractures are really clinical, meaning that we're looking at how the child is using or not using the extremity, the amount of swelling that's there, the amount of tenderness. These things all go together to make the diagnosis of whether something is broken or not. And so in many cases, a child may fall and put their arm out, their hand out and fall and injure their wrists and may favor it. And we may look at it. We may see a little buckle there or a little green stick type fracture, but we may not see anything, but there's significant pain. And so there's definitely a fracture. So the treatment is casting, cast bracing, these types of things. Now, of course, the question would be, with medical science being so advanced, can't you tell 100% whether or not there's a fracture present? And the answer is, of course, definitely yes. But when you kind of look at the expense and the time to give more definitive information, it's really better to just do it based on clinical exam and experience. Because ultimately, you can always, get an MRI scan, and that'll be extremely sensitive. The other types of scans you can get that would actually show 100% whether it's a fracture or not, or just a bad sprain. But in children, you have to kind of put the whole picture together. So if it's not an obvious fracture, and you're getting kind of different answers as to whether or not it's broken or not, and so you're not totally sure. But when you come to see us, if we decide to put on a cast or use a fracture brace or treat it as a fracture, in general, that means that that's definitely the case. And of course, there's some things that are really truly borderline, but for the most part, it's pretty straightforward from our perspective to determine if there's a fracture or broken bone present. And so this provides a little area of confusion sometimes as to what to do about it, because it's inconvenient to have a cast on. And so parents, if you don't want to have to deal with that or have the diagnosis, in many cases, a lot of this has to do with can my child return to sports? So that's a lot of some of the disagreement can be about. And so another aspect of that is when the bone is broken and it's pretty obvious, and let's say we decided to set the bone, or maybe it was set in the emergency room. They gave some sedation, knocked the child out a little bit, set the bone in place, put a splint or a cast on, or maybe we've decided to do that in my office, and I've taken you to the operating room and we've reduced the fracture, set the bones in place, and everything looks good, and we put a nice cast on. And so the next thing is that we kind of follow it periodically. So maybe every week we're getting an x-ray, or every couple of weeks we're getting an x-ray. And then sometimes, and this happens, pretty frequently with children's fractures, depending on where the fracture is, it might slip a little bit off of the position where we had it, or it might slip a lot, meaning that it just like we fix the bone right where it's supposed to be, and then it just slips back, regardless of the cast. And that has to do with the deforming forces and the muscles pulling on the area, the tension of the area, and the swelling going down. There are various factors of why that happens. So then it puts you into a decision mode of, okay, are we going to do something additional with this? So we've gone through the trouble of setting the bone in place, and we have a cast and mobilization. And so that decision point usually rests on how soon this is really detected. And usually it's something that's kind of down the road a little bit. So maybe it's 2 weeks or 3 weeks or something like that. Or even at a week, the same kind of decision point kind of comes into play in terms of risk and benefit versus doing nothing and watching it versus kind of resetting the bone. And one of the benefits of dealing with children's fractures is that there's a lot of remodeling capacity. And that means that remodeling capacity is the fact that the bone will basically straighten out on its own if you kind of leave it alone. And if you really look at some of the dramatic photographs, you can have kind of the bones kind of sitting next to each other, a straight bone that's like pretty crooked. Depending on the age, the location, you can tolerate a lot of deformity. So in other words, you can tolerate a lot of crookedness. Depending on the younger the child is, you can really tolerate almost a ridiculous amount. Now, obviously, that's not optimal. We want things to be, straight and to stay that way. But when they slip off sometimes, it just becomes a little bit more of a waiting game. So in terms of allowing the fracture to heal, and then things to straighten out on their own. And so that can be a little bit nerve-wracking for particularly the parent, usually not so much the patient, because having a wrist that's a little crooked for a while, usually most young children just kind of play through it. It has to do, the parents are very concerned about the future and, future occupation, sports activities, and things of that nature. But I can say that in general, when we've made the decision to treat these without additional manipulation or open surgery, the general effect is, particularly for younger children, that things just tend to turn out well. And so just realize when these things happen, when the bones are set, or even if maybe you come in late, you didn't realize there was a broken bone, and this happens too. You're playing football, the wrist was kind of painful afterwards. It took them a while to decide to finally come in, or the child wanted to play through it, didn't say anything about it, and you come in and it's kind of like a pretty displaced fracture. And, the decision point comes, okay, is this something that we should go in and re-break and then reset the bones? And so, again, a lot of times that depends on the age of the child. So if you're for boys and girls, if you're kind of 11 years or under, there's a lot of wiggle room. For girls, a little bit earlier, you get into 12 or 13, there's a lot less wiggle room. And then when you're getting into the 14 and 16 range, you're kind of leaning a little bit more towards treating like an adult. So there's a little more tendency to need to do surgery and resetting the bone and things of that nature. So there are a lot of factors in treating children's fractures that are different. I think that the biggest thing is that, I have a discussion with the family to make sure they understand that there are these factors. But of course, it takes a little understanding. And, of course, my experience has been, I've seen some pretty wild broken bones that have actually done very well with all the methods. And there are definitely ones that have gotten to me late that I've had to go back in and operate on. But there are definitely ones that have come late that were out of place that did well. So, we're pretty good at really assessing kind of the growth capacity and the ability of the child to heal. So just realize there is an element of judgment when it comes to managing these fractures in terms of the need for surgery, reduction, and repeat reductions as needed. So there is a little bit of an art to it as well. So these are some of the things that hopefully would help you give you some understanding about your child's fracture. I've talked in general about these fractures in general. Of course, each specific area, whether it be the finger, the wrist, the elbow, the shoulder, in my practice, each one has their own set of factors. But what I've kind of talked about generally covers all of them.